Hello, everyone. My name is Frank Qian. I'm a cardiology fellow at Boston Medical Center and the BU School of Medicine. I have the pleasure of sitting down today with Dr. Daniel Gaudet, who is a professor of medicine at the University of Montreal. Thank you for spending time with us, Dr. Gaudet.
My pleasure.
So I know you presented the very exciting results from the SHASTA-2 trial this morning. Can you take us through what was the motivation for the trial and what were the main findings?
Sure. SHASTA-2 was a phase 2b trial, randomized, placebo-controlled, dose-ranging study assessing a new agent called plozasiran, which is a small interfering RNA against ApoC3, which is an important target in lipid metabolism and cardiovascular risk and pancreatitis risk. So this study targeted patients with very severe hypertriglyceridemia, meaning those having values above 500 milligram per deciliter. Essentially, this study randomized patients 3-to-1 on either placebo, 10, 25, or 50 milligrams of plozasiran, and patients were injected. I will explain what this small interfering RNA is afterwards, but injected baseline at 12 weeks with plozasiran and then followed for 48 weeks total. The primary endpoint was plasma TG levels, fasting TG levels, triglyceride levels at 24 weeks. And the secondary endpoint included ApoC3, ApoB, non-HDL cholesterol, and all the lipid parameters. What we have observed is that TG levels at 24 weeks decreased significantly at all doses. It was dose dependent, however, up to 75% approximately. It's not placebo adjusted, it's the absolute reduction. And remnant cholesterol decreased significantly as well. ApoC3 levels and HDL cholesterol significantly increased. The agent was well tolerated and the effect was sustained, meaning that there was a 36-week safety period of follow-up where patients were not injected, but at the end of the year, we still observed significant lower TG levels and remnant cholesterol and higher HDL cholesterol than at baseline. So the drug was well tolerated. ApoC3 inhibitor, there was an agent called vodanesorsen, which was an ancestor, I would say, of oligonucleotide-based therapy. It was an ASO. It was associated with thrombocytopenia, which was not observed with plozasiran.
What do you think is sort of the future for this therapy in terms of, are you anticipating that there will be ongoing trials looking at perhaps individuals with lower degrees of hypertriglyceridemia and perhaps ASCVD risk?
In the phase 2 program, there were already trials targeting patients with lower TG levels, but actually the phase 3 program is ongoing, targeting all the spectrum of TG levels. The advantage of ApoC3 for a cardiologist might be less interesting, but it also prevents pancreatitis associated with LPL deficiency, complete LPL deficiency, which usually don't respond to anything in terms of treatments. But ApoC3 inhibitors act through LPL dependent and LPL independent mechanisms of action. So all the spectrum of TG disorders will respond to an ApoC3 inhibitor such as plozasiran. So we can cover pancreatitis as a risk, fatty liver as a risk. There is no actually endpoint studies ongoing, but what we know, however, is that when you have lower ApoC3 levels, could be because you are carrying naturally carrying a loss of function variant in the ApoC3 gene. There has been a meta-analysis published a couple of years ago. It was in 2018, but approximately 140,000 individuals with loss of function ApoC3. And when you look at ischemic vascular disease, the drivers of ischemic vascular disease in a large cohort like that, the main driver was remnant cholesterol, not LDL cholesterol, because these carriers have low LDL cholesterol, but it's not the way by which they prevent events. So it just highlights the importance of remnant particles on top of LDL particles. So for the future, essentially, we now have an agent which can be injected every 3 months or longer, with long duration of effect, which will target remnant particles, VLDL remnants, chylomicron remnants, and chylomicrons. We already have a lot of agents targeting LDL, so we now have essentially everything needed to cover dyslipidemia. And I just add something here. ApoC3 is an independent risk factor for cardiovascular disease, at least very well demonstrated in type 1 diabetic patients, but clearly particles such as LDL, which are depleted in ApoC3, are less heterogenic. HDL particles depleted in ApoC3 are more efficient. So decreasing ApoC3 is good, essentially. So the future, to me, will lack data because the phase 3 program is just starting. But combining what we have in hand, what we know actually, and it's really fun. I usually appreciate when an agent is developed around a naturally occurring phenotype in the nature. It has been true with PCSK9 inhibitors, with MTP inhibitors, ANGPTL3 inhibitors, and other. So it's great. And to me, if these agents are affordable and available, it will be great.
So I know one of the concerns that was raised in the Q&A session was that there seemed to be a small increase in LDL as well as perhaps worsening of glycemic control. Can you comment a little bit on how clinicians should approach that?
When you inhibit ApoC3, whatever the mechanism, you can expect that LDL cholesterol might increase or the LDL particle number might increase because the catabolism of VLDL is hugely accelerated. So you produce more rapidly, more remnants. Half of them at least are cleared. That's why it decreases LDL TG levels. But eventually, LDL particles will be formed. But these LDL particles are depleted in ApoC3, thus less heterogenic. Remnant particles are absent. And honestly, LDL cholesterol now in 2024, it's quite easy to manage. So if LDL cholesterol increase, it doesn't occur in all patients, but when it happens, and it is expected, you can up-titrate the statin or the PCSK9 inhibitor or the ezetimibe, but a treatment that is used to treat this patient, or if needed, you initiate a statin. So to me, and statins are not expensive. So to me, managing the LDL part of it is simple if you understand that LDL cholesterol increase might be expected by principle when you decrease ApoC3. And again, I come back to carriers of naturally occurring variants in the ApoC3 gene, loss of function variants, who by nature are cardioprotected and by nature have low TG levels, but LDL cholesterol is not a part of their phenotype. It's clearly a remnant-driven protection. So it just adds to the knowledge that we already have. LDL remains important. Extremely important, but now we have something to fight the risk associated with remnant particles and for non-cardiologists to target chylomicrons and the risk of acute pancreatitis. As for glucose, honestly, it's not a concern to me because, first of all, ApoC3 is a protein which has deleterious effect on glucose homeostasis. ApoC3 can contribute to beta cells apoptosis, to insulin resistant and the captation of fatty acid by the liver. So we are not expecting that we will contribute to a deleterious effect by inhibiting ApoC3. However, what happened, and it happened with vodanesorsen, which was an ASO as well, for a while, glucose might increase, as a matter of fact, in patients with type 2 diabetes. And probably, and the mechanism, it's transient. Can take a year or so to eventually normalize. It requires adjustment of glucose medication if needed. But again, it's transient. And the reason might be that when you rapidly catabolize TRLs, triglyceride short proteins, you generate a lot of fatty acids. and you clearly affect neoglucogenesis. But it's not it's an effect which, when you know that it will happen, it might happen, you just be prepared. It's easy to manage.
Great, thank you. And I guess one other question I had just from the clinical perspective is, do you foresee that in the future, patients who have severe hypertriglyceridemia or even moderate hypertriglyceridemia, will we just go straight to these, ApoC3 inhibitors, or will we still have to, start off with fish oil fibrates before we get to that stage?
Fibrates, they are less popular than before because their benefit is mitigated. However, they are useful. You can use fibrate to highlight the LPL bioavailability or not. It might be helpful among at least patients with very severe hypertriglyceridemia. As for omega-3, it's a different story. They have ApoC3 is pro-inflammatory. Omega-3 are anti-inflammatory. So, the benefit of omega-3 is less pronounced than for other agents, maybe. The REDUCE-IT study, at least has been positive. So there's a future to maintain the access to these agents. But I will just bring on the table other new agents in development, including ANGPTL3 inhibitors. ANGPTL3 inhibitors, they are in clinical development. Several of them are evaluated for severe hypertriglyceridemia as well, and it will work. But these agents, anyway, they work. They are very effective for homozygous FH, or for those patients lacking LDL receptor, because they are LDL receptor independent, but LPL dependent. It's complicated, but what I'm saying here is that if you want to use an ANGPTL3 in the future to treat severe hypertriglyceridemia, those completely lacking LPL will not respond. However, you will decrease LDL cholesterol at the same time. So what's the future for ApoC3 inhibitors versus ANGPTL inhibitor? To me, they are complementary. But the toolbox is, when I was trained, we were evaluating the 6th or the 7th statin. Now we have new agents with different mechanism of action. This interesting. Plozasiran is a small interfering RNA, a double-stranded oligonucleotide. Olezarsen is a single-stranded oligonucleotide. We have gene editing coming soon. We have new emerging agents of monoclonal antibodies, including for ApoC3 inhibition, by the way. So now we have a toolbox with different targets, very, very promising targets, and very different and complementary mechanisms of action to fight cardiovascular disease and other risks.
Well, thank you very much, Dr. Gaudet. And to watch more videos like this, please check out youtube.com/FITsOnTheGo and follow us on X @FITsOnTheGo.